So I'm David Unwin, a GP from Southport, and I wrote this speech specially for all the N=1 people who've made such a difference, because I became upset that they were being ignored and told they weren't relevant to science. And I hope I'm going to show you in the next half an hour exactly how important you are and the difference that you can make. And we should just rush through the disclosures. So what should I disclose? So I said before, nobody pays me for anything. I am actually the Senior Medical Advisor to diabetes.co.uk, but they don't pay me anything at all. So it's important you know that. So let's get on with the talk. And it's entitled, Why Black Swans Matter, because I'm here in Australia, so I wanted to give it an Australian kind of a thing. Black swans, right? So you've got a prologue, and the prologue really is a repeat, but the point is that one single patient who impressed me has in the end possibly affected maybe 1 million people. That one patient, what a difference she made. Certainly through the low carb program, we've now done 450,000 people. And I wouldn't have done it if that very first patient hadn't come to me and shown me that remission of type 2 diabetes was completely possible. So this is the prologue, which we can do very rapidly. So basically, if you have type 2 diabetes, glucose can be thought of as a sort of poison. We need to get table sugar out of the diet. But then again, what if you've already done that? What if you've already done that and your diabetes is still a problem? And that lady taught me that starch is sugar. And I needed a patient to tell me that. And again, it's revision, but a starch molecule is lots of glucose molecules holding hands. And digestion turns it into absolutely lots of glucose once again. And I've shown this so many times, but this was my interpretation to help people understand the consequences of dietary choices, so that, based on the glycemic index, a small bowl of rice is the same as 10 teaspoons of sugar. A slice of healthy brown bread is the same as 3 teaspoons of sugar. So that not necessarily very good dietary choices for people with type 2 diabetes. And once I understood that, I was able to start within my own practice in Southport, and by implementing a low-carbohydrate diet. This slide is already out of date. We've now got 71 cases of type 2 diabetes remission. These are people who have come off drugs. And that summarizes the improvements in lipid profile, improvements in liver function, in blood pressure and weight. And so I started there, and then we went on to the low carb program, and as I say, that's 450,000. But that's probably not, it's still growing, all from that one patient. So much so, to find an Australian link again, so the Legislative Assembly of Western Australia came 9,000 miles to Southport to meet my patients and scrutinise my data. And then afterwards, they were kind enough to say, there is convincing evidence to support the use of dietary interventions such as the very low-calorie diet and the low-carbohydrate diet in the treatment of people with type 2 diabetes. So that one lady that came to see me in 2012 has now affected at least 450,000 people through me, and even the government of Western Australia. So wow, isn't that amazing? What if you could all do something like that? Wouldn't that be amazing? So, oh, I'm just pointing the black swan there, because this is kind of supposed to be about black swans, so you're probably wondering where they come in, but there is one there for you. Yeah. So, in a way, I think we've done that. I think we've solved diabetes. It's very easy and we've solved it. So how about we move on to another subject? Perhaps you're bored of me talking about type 2 diabetes, so why don't I talk about something else? And high blood pressure, it strikes me, is very, very important. And we know that high blood pressure is the second biggest global risk factor for disease after poor diet. It's absolutely huge. And yet very interesting, very interesting. So, it was a few years ago, I was talking amongst the doctors, we were at coffee time, and I said, I wonder what the cause of high blood pressure is. And they said, don't be silly, David. That's why we call it essential hypertension, because we don't know the cause. And I'm saying, well, does that not, should we not be interested, if it's so massive and we're prescribing drugs every single day, shouldn't we be interested in why this is? And no, it's essential hypertension, David. We're not, right. So it was interesting, earlier this year, the Times gave a thing, and it said here, right, it's simply a result of aging of the circulation, because the heart has to pump harder to maintain flow through those stiffened arteries. So, well, there we are, we can relax, because that's the cause of hypertension, because it's in the Times. It's in the Times. And then I thought a bit more about it. What if essential hypertension, maybe it's about weight? And there have been people who say that it is about weight. And certainly if you look at this case here, this is somebody who is losing weight on my low-carb diet, and you'll see over time their weight, the two graphs are contemporaneous, and if you look, the weight comes down and the blood pressure goes down. So maybe it is about weight. But here's my first black swan. Here's my first black swan, a different lady. A different lady taught me something. Here's a black swan, and so she, 50-year-old lady, only weighed 8 stone, 12 pounds. And she had a very high blood pressure, as you see. And she wasn't at all overweight. So that challenges the idea that weight is to do with hypertension, because there's quite a small person and quite an unfortunate blood pressure there. So, some more stuff started happening. Some more things started happening. I wonder if you can guess what that is. Perhaps it's Lucozade, that yellow thing. This has made my wife Jen very cross, because that's actually her measuring jug out of the kitchen. And I'm sorry to tell you that it is urine. It is urine. But what I noticed was when I went low carb, I started weeing loads. Perhaps some of you in the room have noticed that. You just wee loads. You can't believe I'm up again and again. And after a bit, I started measuring it because I was so fascinated. How much urine was there? Pints and pints. I had one patient and he lost 5 kilos in a week when he first went low carb. And the only way that you can lose 5 kilos in 1 week is fluid. So my patients were weeing loads when they went low carb. Isn't that interesting? That's something to notice and think about, because it's odd. Then the next thing I noticed was many of the patients were, certainly they benefited from salt in the diet. They seemed to need more salt, and I did. And if I gave them salt, they felt better, and they didn't get that sort of keto flu at the beginning. So salt seemed to be important. And right across the world, people were noticing that you need salt. And that's kind of odd, because I thought salt was supposed to kill us all. Certain death, this salt stuff. So I became unhappy, because I thought, am I advocating something to my patients that's really bad for them? And So the way that salt is supposed to be certain death is it's supposed to put your blood pressure up, isn't it? But here was another really weird thing. I'd had high blood pressure for years, so my blood pressure used to be around, not very high, but just slightly high, like 160 over 90, 160 over 95, something like that. Of course, I never went to a doctor or told anybody, because that's a terrible idea, but I just quietly worried away. And then I noticed another thing was, if I stood up too quickly, I felt faint. I had to hang on to the desk. This was really new for me because this was actually low blood pressure. So I was 55 and I did my blood pressure, yippee, 130 over 70. What on earth was going on? This new thing. So I was having more salt and my blood pressure went down. Completely mad, completely mad. So what was going on? I was noticing things. And so here we are. I've introduced the Black Swan lady. The Black Swan lady, and she went low carb. Now, she went low carb because she had fatty liver, which was another really weird thing, given that she was so small. And a completely unexpected thing was her blood pressure dropped so much she felt dizzy. And if you look at some of those levels were so low, I was forced to stop her perindopril, her drugs for hypertension. So that was one of the very first cases where I was forced to deprescribe. And it really fascinated me because I couldn't understand what was going on. But it started happening in lots and lots of patients, not just one, not just two, and then there were 18 who I wrote up, and then there was 30, and now there are 252 in the total cohort. Here's another one. Here's another one. So this patient had been on medication for his blood pressure for years, and you'll see there he came off amlodipine, a big dose. He came off irbesartan, so he came off 2 drugs for his high blood pressure. And even so, his blood pressure, as you can see, the graph there on your left, his blood pressure is still really good, despite the fact I've stopped all these drugs. He's there as a black swan because some other interesting stuff happened to him. The most important was he had been on Prozac, which is our major antidepressant, for 11 years. Really, after 11 years, nobody comes off Prozac. That's a one-way thing. In the old days, after a while, I'd start adding in a second antidepressant. So you'd increase the dose of the first one, and then when that didn't work, I'd add in another one. I used to add in venlafaxine, a second one. But this guy kind of cheered up. Weird. He kind of cheered up and went lively, and actually I thought it was slightly manic. I thought, oh, you're a little bit worrying now, a little bit too cheerful. So we reduced the Prozac, and then he came off it. He couldn't believe it, and he said it was so wonderful because he said actually on Prozac he didn't feel like happy, he just felt vaguely dulled. The pain, the misery was sort of dulled, and he said, I feel normal now. That made him a really significant black swan for me because I hadn't seen that before, not after 11 years. His case shows you something else. Can you see the triple dipping there? The triple dipping. So what is happening is his weight goes down, but then for some reason it goes up again. Then it goes down again, but notice the second time it goes down deeper. Then the third time, it went lower still. I wonder what that reflects, that jumping up and down. Now, I actually think it may well reflect addiction to carbohydrate. He's struggling to give something up. He knows he should. He feels better when he gives it up, and yet he does the very thing he doesn't want to do, the thing that makes him ill, and back he goes. I would just say in clinical practice, that is not failure, you know, when his weight went up. I didn't see that as failure. I saw it as a chance for him to learn, how would you do Christmas better? Because some of those were Christmas. Next Christmas, don't beat yourself up. How would you do Christmas better? And look how every time he did it, he learned something. I have a number of these triple dippers, each one better, and that's called learning. That's called getting older and learning stuff. So he's a black swan in lots of ways. Just another case. This guy, yeah, he's remission number 66. Remission number 66. And he also makes the point that it wasn't just his diabetes, but he came off his medication in about 3 weeks. And also his lipid profile's improved. Let's just talk about this black swan thing. This black swan thing. So if you took school children, if you took my grandchildren, so if I was to ask Lucy, my adorable grandchild who is 7 in the UK, what colour are swans? In the UK, she's going to say swans they're black, Papa. She calls me Papa. They're black. Sorry, they're white. She's in England. She's in England. Swans are white in England. Okay. And I'd say, so Lucy, are all the swans white? And she'd say, they're all white. Don't be silly, Papa. They're all white. How interesting. I come to Australia and I say to a child, so what colour are swans? Your swans, they're weird because they're black. So, are there white swans? No. In England, are there black swans? No. But if I show Lucy one black swan, my hypothesis that swans are white is finished. Because if I show her one black swan, the hypothesis is dead. Okay. If I have a hypothesis that type 2 diabetes remission is not possible, I see that first lady, I know it's possible. Black swans are so, so important, and we should look for them. In good science, we should be fascinated by black swans. We shouldn't discount them, and I see across the scientific world people with interesting histories being rubbished as you're only an n equals 1, like you're a story. You're just a story. And yet, if you've shown it once, it's possible. The next thing, okay, you've done it once. Can it be replicated? Can it be replicated? Is it just one black swan, or have you got more than one black swan in Australia, I wonder? I've seen 2 or 3. There may be more than 3, I don't know. But we're seeing more black swans, okay? My type 2 diabetes remission, I'm up to 71. So this is looking like a bit of a thing now. There's 71. And here's another really important point about black swans is there a reasonable body of physiology to explain type 2 diabetes remission? Have we got a theory that it kind of, and then you think, well, if diabetes is broadly about sugar and you give up sugar, and then your diabetes seems a lot better, that kind of makes sense. So that we should look to physiology for are our black swans reasonable? And I think I have an idea there's far too much epidemiology, is my personal feeling, and not enough physiology, because that's kind of better science and a good way to look at these fascinating black swans. And then my final thing, if you are collecting black swans, think about data. And that's what I did. So I had one black swan, type 2 diabetes remission, and it fascinated me. And then I got a few more. So why don't ordinary clinicians start collecting data? Because that also adds real value to these things that we're noticing. Collecting data. So now we come, so I got all these. As regards blood pressure, I think I ended up with, about 150 in a separate kind of blood pressure box in my head, worrying about why was this happening and why, and yet I was giving them salt. And I was searching and searching as to why should this be. And this is a rather boring slide, but what you've got there is some references. And who knew that the physiology of this has been sorted out for years? And I love going around cardiologists now to say, what are your thoughts on salt and the kidney? And you know, is there anything at all about insulin? And they know, no, there's nothing. That's not true. So the actual physiology underlying this is that if you have type 2 diabetes, you would tend to have a high insulin level, and many of you in Australia can measure that. Insulin for people with type 2 diabetes causes you to hoard salt. You're not weeing out the salt, you're hoarding it. And with the salt you're hoarding comes fluid. More fluid in your system is increasing pressure. That's really simplistic, but there is perfectly good science that's been around for years to say that insulin causes you to retain sodium or salt. And that sort of fits in with all these other things I'd noticed. I'm weeing loads because I go low carb, my insulin levels drop, suddenly my kidneys are releasing all that sodium I'd hoarded, taking with it lots of fluid. At the same time, within days, I'm feeling faint if I stand up. So there you have a black swan, something I'd noticed, a clinically interesting thing, and some physiology to underpin it. So the next thing is to write a paper on it. The next thing is to write a paper, and this is what I'd say to clinicians, is I always used to think that the likelihood of a GP or just an ordinary clinician contributing anything to science was really small. And in a way, it's a bit like patients who feel the likelihood of them contributing anything to science is really small, and yet that lady contributed something. And I'd say, clinicians, if you notice things, and then you collect data, and you can underpin it with physiology, well, maybe you could write a paper. Because so often I find that academics don't think I have anything useful to contribute. Because they say, you know, you just do the clinical stuff, David, and we will sort out the guidelines and, you know, the proper science and all the rest of it. And yet I think clinicians, I think we're very important. Just as patients are important, I think clinicians are important. So this is a paper I published a few months ago. And of course I'm going to show off again, because I like showing off, but it makes a point that this paper, now there have been, I think, 1,400,000 papers published ever. And this particular paper, they measure the popularity of papers with an altmetric thing. And this paper came as 9,500. So it puts it into the top 1% of all papers ever published, which is mad and bonkers, completely bonkers, because it started off with a woman, and then, you know, she this, that, and the other. She wasn't fat, that sod, and me weeing into a jug. And it's like really weird, because it's done rather well. It's done rather well. And here's one of the things that has caught the imagination of people. If you look at the circle there, actually, I ended up taking away 21% of all the drugs the 150 people were on, 154 patients, and I was taking out all those drugs. On the right-hand side there are the drugs that I ended up taking out, and there's also the reference for anybody that wants to look at the paper, which is open access. And here's the thing. So I'm taking out all those drugs, but look at the blood pressures. So even despite taking away drugs, those improvements in blood pressure are highly significant, as you see from the p-values on the box and whisker. So the box and whisker are a way of showing distribution, and that the mean and the median and the percentiles are all changed significantly. Here was a thing that was very surprising. This went wild on Twitter when I popped it on. That this was the improvements in lipid profile. So that they'd gone low carb, the blood pressure had improved, and again people think, well, probably the cholesterol will get worse because they're on full fat everything, and and yet look at the p-values, the lipid profiles improved really significantly. And if you can improve lipid profiles and you can improve blood pressure, that's a really great clinical thing to do. Now, there may be some risks in what I do, but if your weight is better, and if your blood pressure is better, and if your lipid profile is better, I just wonder where the risk would come from. You know, just a question there, just a question. So back to the consensus report. This is a wonderful, wonderful thing published this April. The consensus report from the American Diabetes Association, commenting on the low-carbohydrate diet and the very low-carbohydrate diet. And they actually tell you, so this is in the consensus report, a massive thing. They point out that blood pressure lowers there. They point it out. I don't think we talk enough about the blood pressure improvements that so many of us notice. So many of us notice in clinical practice. How about some of the black swans? How about some of the black swans? Heart failure. So a story. I had an 87-year-old gentleman come to see me with his wife, and I'd looked after them for 30 years. He was he still is a really great guy. Very macho. He'd make a good Australian. He's very, very macho, and don't mess with him. Don't mess with him. But actually, it was very sad because he was sick. He had heart failure, and I'd used every single drug I could think of on him. And when you get to that point in heart failure, those people usually don't have long to live. And his wife understood that, and she said, there's one thing though. The tablets I was giving him were causing him to wee all the time because I was trying to get the fluid out of him. And he was needing the toilet the whole time. And that was very embarrassing because he had what you see for older people, which is a fast bladder and slow legs. If you get that. And so his wife said, this is really embarrassing. Is there anything you can do, Dr. Unwin? Because I know he's sick, but it's his dignity it's taking. So I said to him, I said, are you up for something? Could we do a weird thing and try this low-carb diet? Try this low-carb diet. And he was a big fellow. He was a big fellow. Well, a month we did this. Now, within a month, that guy was gardening. And his wife said, I can't stop him. Is he in danger? Because he's moving about so much. And I can't, you know, he's cleaning the car. And he hadn't mowed the lawn in years. And this fellow is still alive now. And I did that years ago. He weed and he went low carb. He weed, which for a few days was really bad. But then he stopped retaining the fluid. And I was able to stop the frusemide. So the drug that I'd got him on was called frusemide, which forces your kidneys. It's a mallet on the kidneys. It forces the kidneys to put out the fluid. But he suddenly could regulate his fluid normally. Now, this is only one case. But actually, I've done it a second time. So that's 2 black swans with heart failure, because it's borderline stuff, this. So folks, don't go home and please don't stop all your heart failure tablets, just because, don't do that. But, you know, I'm a doctor. I did it with my patients. I consented them. Each of them felt they'd nothing much to lose because they knew how sick they were. And that's 2 I've done. So that's a black swan. This is liver function. This is a graph of, it's actually the patient who's had his diabetes in remission longest of all my patients. It's at least 9 years. Now, some of you will remember that I said I started in 2012, so how come this is 9 years? Well, there's an interesting story behind this guy. He did it all by himself, but never told me because he knew I'd rubbish him. Okay? So he did it years ago, 2008. He was my patient who did it in 2008, but he was very careful, like so many people in those days, not to tell his doctor. But then he was really annoyed because on Twitter, he found that I was celebrating my longest patient was 6 years, and he came in saying, no, I am your longest patient. And he said, go on, send me for a blood test now, but you've got to put me on Twitter, and I want to go around the world. And And I owe this guy because look, we did the blood test. Now, in this case, for the purposes of this slide, I'm demonstrating his liver function. So I thought his liver, if you look, was terrible. This is liver function, bad. Up is bad, down is good. So I thought I didn't know why his liver function improved. I never asked him. Okay, I never asked him. I just thought, oh, it's got better, that's good. I wonder why that's happened. Probably no reason, these things just happen, you know. They just happen. And if you look at the graph, I got bored of doing his blood tests. So he hadn't had a blood test for years because I just thought, oh, it's fine now, never asked. So we did the blood test again just for the purposes of bringing it up to date. So years go by. I hadn't done a blood test since 2015. But there we are, 2019. His liver function is absolutely spot on. And hemoglobin A1C of 34 is really good. Okay, I know you don't work in millimoles per mole, but that's really good. So there was a black swan I missed. There was a black swan I missed. I could have been helping people back in 2008. He would have loved to have told me. He would have loved, but he tried with one of my partners. He did try. He went to see one of my partners to say, I'd like to come off my drugs for diabetes because I've cured it. And my partner, who we won't name, just rubbished him and said, no, don't be silly. You know, and they had a massive argument because the guy wanted to be recoded on the computer system as non-diabetic, which would have helped his insurance. And there was a massive fight and he just went away for a while. But he did come back to me eventually. So that's interesting, isn't it? I missed that black swan. I missed that one. Here's a more recent one. So this is a lady who, very fond of this lady, and I'd had her on this frusemide. You know the drug frusemide that squeezes the kidneys? I'd had her on frusemide because her ankles used to get massive. Massive. And then her skin used to be like a tomato that's going to split. And I used to worry that she's going to get a leg ulcer. So she was on frusemide because that will sort that out. So I'd really cured her, you see, without any thought at all in my head as to why this lady had big ankles. And, you know, was it frusemide deficiency? Perhaps it was, because I gave the frusemide and it worked. But there's an unfortunate thing about frusemide. Over time, it actually weakens renal function. And over time, it can make it, one of the side effects, it can be diabetes. So it's a bit of a sticking plaster rather than actually a wonderful solution. I can't remember now how I came across it. I think it was another one of these, I love this idea of, shall we have a go? Shall we try this? So she came to see me about something else. And, oh no, it was diabetes, that's right. She was sent by one of the other partners, diabetes. But again, after a bit, she came in and said, look at my ankles, Dr. Unwin. And that happened within weeks. And she said they were so good, I came off the frusemide. I hope that's okay, because I haven't taken it for a while. And I'm just like, and those are that lady's ankles. So, you know, she'd say, just go on, put them on Twitter. Go on, do it. I want them on Twitter. Great woman. And no wonder she's proud. So the world has seen her ankles. Right. So we've more or less come to the end there, but just some reflections. So this is about celebrating n equals 1. It's about noticing them and asking and saying, isn't that interesting? Maybe I can learn from anybody. Maybe we can learn from people. Maybe your story has some relevance. And then if we find several of you, start collecting data. And then revisit physiology or try and think, how might this fit in? And in a kind of way, isn't this science? Isn't this science? Or a different kind of science? And then the other thing I'd like you to think about, I also wrote this speech for the n equals 1, but I also wrote it for clinicians. I wrote it for clinicians. Oh, I wrote it for clinicians because we matter. and we care. And I have been rubbished so much. And the things we notice, the things we do, should also form part of science. And there's a wonderful idea that my wife taught me recently. She said, there's two things about validity. So you want your science to be valid. There is a study would have internal validity. This is the old-fashioned studies. Would have internal validity if you got rid of all of the variables. So this is the RCT, where we're looking at blood pressure, but you don't allow patients on that who've got depression or arthritis or on drugs for anything else. So you only had one variable, and then you know the drug treats the variable. But I had a problem with that because all my patients, they're kind of older and they have obesity and they're depressed, and the average person in the UK over 70 is on 4 drugs. So the studies don't represent my patients very well. There's other kinds of study, the opposite of the ones with internal validity are the ones with external validity, and that's kind of what clinicians see. These are my cohorts of ordinary people. So in them, my work is a mess. It's a mess because it's just a cohort of people, and they're ill in different ways and all sorts of different drugs, and people say, yes, but what is the diet they're eating? And are we testing them every day? No, they're kind of just living life, and then stuff happens. But this kind of research has external validity, and it rolls out well, because nearly everybody in this audience has done that. I know it's worked for you as well. So stuff that rolls out and has external validity is also important. So in the balance of science, what we need is a value of internal validity. We need those studies, but we also need people like us with external validity to check it works. So let the clever guys do the internal stuff, but the external stuff, it's been neglected, and we haven't, I think, been belittled a little as not important. And I want the clinicians get braver. So I want the public to get braver. If your case is unusual, then ask why, and are there others? But I want the clinicians to look for these black swans, collect data, and publish. Because if I can do it, as Mr. Nobody from nowhere, who's heard of Southport in Lancashire? Nobody's heard of that, just the GP. Well, surely lots of other people can do it. And here's another thing. We seem to have started valuing massive studies. So I found in 2012, all I ever did was say, well, how many was in the study? Because I had an idea that the bigger the study, the more value of the study. So if I saw a meta-analysis and there was 3.5 million people in the meta-analysis, well, that's definitely a good study. And then I'd see a study with 50 people in, and that, you see, that's a rubbish study. Do you see? Because size always matters, always. And I'd kind of missed out the quality thing. And I think people all over the world, we're more impressed than we should be by very big studies, because we should be thinking about the two things, the quality of that study and how you would measure that quality. But here's another thing. If you had a study with 50 people in, and those 50 people were really like you, that study could be highly relevant to your case. You'd be far better to look at that study and what they did than a study of, let's say, an international study of 3.5 million people taken across the world. Well, are those people like you or you? I've no idea. So you see, there's a place for the small things and a place for the big things, and we need to become discerning and think about it. I'm sure I've used up my time. Just one last N=1 to finish. There's Chris. A really important N=1. I think actually he was probably the first patient. Chris was I think I wrote his case up in the British Medical Journal because I was so amazed to stop his perindopril, which is his drug for high blood pressure. So he's the first one. That's been very exciting. Thank you so much. Thank you very, very much.